Okay, so and I'm really, really excited to introduce the keynote session with Amy Lang. So Amy is the Executive Director of Patient-Oriented Research at the Canadian Institutes of Health Research. In this role, Amy provides leadership and expertise for Canada's strategy for patient-oriented research and other patient-oriented research activities. And this, I'm sure Amy will talk about this, but this really reflects CIHR's organizational commitment to patient-oriented research as well as the funding commitment to the research community. The session will be facilitated by Laura McNab Coombs, and Laura is an Indigenous health research facilitator with the BC Network Environment for Indigenous Health Research. This is the BC NEIHR, so there's a series of those funded across the country by CIHR, so we're fortunate to have Laura with us here today. So welcome to Amy and Laura.
Good morning, everyone. Thank you so much to the organizers of the conference for inviting me here today. I actually did my dissertation research and lived in BC during my postdoc, and I left in 2010 and I haven't been back since. So this invitation is like coming home, which is wonderful. So my name is Amy Lang. I'm the Executive Director of Patient-Oriented Research at Canadian Institutes of Health Research, which, as I think you all know, is the federal funding agency for health research in Canada. And I've been in my role for about 1.5 years at the organization, but I've been connected to SPORE for a lot longer, because before joining CIHR, I was on the knowledge user side of a lot of SPORE-funded research in my roles working in the health system in Ontario. What I've been asked to speak about today are a couple of things. One is just where are we now as a community in terms of patient-oriented research in Canada? And the news is good, and I'm happy to be here to share that news. I also think, though, and this is based on a recent evaluation that was conducted of our program, that we have some more work to do together. And so the third part of my talk will really be talking about where I think we can spend some of our time and energy thinking together about what the future of SPORE needs to look like. But before I get into that, I was asked by the conference organizers to talk a little bit about what brings me to patient-oriented research and what connects me to the community. And as I started to think about it, I without wanting to get into my entire life story, I really reflected and thought it's not one single experience that brought me into this work and this really wonderful national community. It's not one experience that brings me here today. But I will share two experiences and this is a bit of a different thing. I will say I've never done this before. So if anybody has any concerns or if it gets kind of weird, Sterling Bryan is sitting at that table right over there. It was his idea. You can take it up with him. The first experience I wanted to share was from when I was growing up. So I grew up in a house with a mom who was a participant in the second wave of the women's movement in Canada. And as many of you know, this movement started in the 60s and 70s. It was an international social movement, and it continued on into the 1980s and 1990s, which is when I was growing up. And again, I'm sure many of you know, this is a movement that had a significant focus on a lot of the different inequities that existed for women at the time and still persist, including unequal pay, sexual harassment and violence, and control over reproductive health. And I remember marching with my mom and friends at International Women's Day rallies. This was the one from 1990, pictured in Toronto. And in addition to marching in rallies and talking about these issues at home, I vividly remember this book on my mom's bookshelf called Our Bodies, Ourselves. So I'm sure that many of you know this book. It was developed by the Boston Women's Health Collective in the 1970s as part of the discussions that were centering around women's issues at the time, and it was groundbreaking. It was groundbreaking because it was founded on the idea that women's own knowledge of their bodies was as important as the knowledge guiding the medical establishment. And it covered topics that were important to women that weren't well covered in their interactions with the health system. Topics like sexuality, birth control, abortion, menopause. Topics that were really important to women, but where it was really difficult to find good evidence-based information at the time in their care. Another important thing about this book was that it incorporated stories of personal lived experience. And by juxtaposing that with the evidence, the scientific evidence that was available at the time, I think the book reinforced the idea that lived experience was really important and that we had something to learn from it. So what having this book on our bookshelves at home when I was growing up, what it did was it instilled in me from a really early age a particular perspective on health that centers lived experience and empowerment of individuals and communities to take ownership over their health. And this is something that we saw, of course, not just in the women's movement, but also in many other social movements, whether it's disability rights, the HIV/AIDS movement, the civil rights movement, and later the Black Lives Matter movement, Indigenous movements for liberation, LGBTQ2S, and others. So for me, one of the things that connects me to the work of patient-oriented research is that I see it as a very important continuation of the work that these social movements started. And it's a really important call to action for all of us who are involved to do the hard work of translating the values and the things that those movements were advocating for into the systems that we work in. And that's one of the things that motivates me and connects me and keeps me going in our work together. Fast forward 25 years. The second experience I thought about sharing today is actually probably my only real patient experience. And this occurred before I worked in the healthcare. So I really had a layperson's understanding of the healthcare system at the time. It was 2012. I had just given birth to my first child, a daughter, named Ruby. And 6 weeks into being a new mom, I developed an abscess in my breast, which was the result of an untreated infection I got from nursing. And it's something that up to 3% of people who choose to nurse experience. So I was sent by my nurse practitioner to a local emergency room in downtown Toronto, which was part of an academic hospital, along with my 6-week-old baby and my husband. And there, a doctor drained the abscess and left a tiny pinprick on my skin. And then a nurse came in and looked at the pinprick and put a Band-Aid on and sent us home. But unfortunately, that kind of procedure leaves a cavity under your skin. And what ended up happening is that I developed a wound about the size of a toonie that needed more than a Band-Aid to heal. That wound would persist for 8 months, which was the majority of my baby's first year. And nobody seemed to know how to treat it. So my nurse practitioner, who I actually had a great working relationship with, gave me bandages that stuck on and reopened the wound when I tried to change them. And the family doctor that she called to consult just looked at it in dismay and was unable to offer any advice. And my own sister, who is a nurse herself, and had worked in a cardiovascular surgery unit, so she had some experience with wounds, all she could tell me was, "It doesn't look deep to me," but she had no advice about where to go to get help or what I could do. Eventually, I was referred to a breast cancer surgeon who seemed to have the attitude that was captured in this quote that I found in putting together these slides. The idea that this is a trivialized local infection. He was pretty dismissive. It seemed to me that he thought he should be dealing with people with more serious problems. This wasn't the kind of illness that he wanted to be working on. He was able to help me, but he said that I had to take care of myself, essentially. He said home care was too busy to see me, he didn't bother with a referral, and he sent me home with some silver nitrate sticks and told me to cauterize my wound once a week. So once a week for 8 months, I hope this doesn't gross anybody out, but this is the reality. I had to do that. I had to burn the wound in the hopes that it would heal. And as you can imagine, it was really painful, and I felt very isolated and depressed, pretty significantly depressed by that experience, along with all the other feelings that come along with becoming a new mom. So thankfully, this was really an isolated experience. That is really the only time where I've had that kind of prolonged experience and interaction with the healthcare system, and I feel really grateful for that. And I think about it often because although I don't consider myself a patient as part of my identity, that was really, for me, an isolated experience. The experience helped me understand themes that I've heard again and again from people who do interact with me as patient or caregiver advisors. And some of these are up on the screen. So some of the recurring themes that I've heard about in the 10 years that I've been privileged to work in the field of engaging with patients and caregivers are things that I experienced too, like the siloed and fragmented nature of our health system, the feeling of being bounced around among providers, the struggle to get care for a condition that seems like it's outside of the norm. And of course, I've heard many other experiences that really make me reflect on that knapsack of privilege that I was carrying around the whole time that I had my experience, where I had white skin, English as a first language, I had cultural capital in the form of a PhD, I had a supportive family network, despite the fact that my sister, didn't know how to get me access to medical care. She was a great emotional support, and I had lots more, without which my own experience, I think, could have been a lot worse. Thinking about this and what I've heard from other patients and caregivers also really gives me insight on health research as well, I think. Because my story, along with so many others, I highlight the value of patient insights in highlighting gaps in what we know and what we don't know about how to treat various conditions and what are important outcomes. So that experience with the breast cancer surgeon, his outcome that he's really worried about is life and death, which is important. But my outcome that I was worried about was well-being and how do I care for my baby and bring the joy that I wanted to in her first year. I think my story is also a story about knowledge mobilization. In addition to what could we be doing research on, it's also about how do we mobilize the knowledge that we have. Because at the time of my experience, there was good evidence and good protocols on how to treat wounds. And we actually probably knew how to care for abscesses related to mastitis, to infections from nursing. And we knew about postpartum depression. But the clinicians that I had access to in one of the most well-resourced health systems in the world with lots of access to health research still didn't know how to pull that evidence together to care for me. So to kind of wrap it up, I don't currently identify as a patient or a caregiver, although I know one day I will be again. But this personal experience, and I'm sure this is the case for so many people in this room, is when I think about it, it helps me to be sensitive to the value of lived experience in exposing what's missing both in health research and in health care. And it helps me to have empathy and gives me energy to keep contributing to the work that we all do together. And I imagine that's the case for most of the people in this room. And to move into, where do we need to go with this? I think we're going to need that energy because we have a lot of work ahead of us. So there's no question the SPORE community has really achieved a lot in its 10 years. And I say this as someone coming in and just kind of being astonished at how much has been achieved. I mentioned that CIHR had recently finished its second evaluation of the SPORE program. And this is an independent evaluation team that is completely separate from the team that manages the program for good reason. And they concluded that the program really has value and needs to continue. And not only does it need to continue, but that the lessons learned from SPORE, we should apply it to other funding programs at CIHR. So I would like to take a moment and give you a round of applause for that. Bravo. Seriously. I can't take credit, but I feel like I get to stand on the shoulders of giants in the work that I now am privileged to do at CIHR. At the same time, what the evaluation found was that we still have really important work to do because although there are lots of individual examples of success in the work of the SPORE community, it's still kind of fragmented. And we're going to have to do more work to really fulfill the vision of SPORE, which is actually two things, and one of which I think gets forgotten sometimes. So the original vision for SPORE was both to embed the perspective of patients and caregivers and communities, people with lived experience, into the research process, and it was to take the results of that research and mobilize it into health policy and health care. And I heard that from our patient partner group in their introductory remarks. The motivating factor for so many of the patient and caregiver and community partners that I've worked with is not just to do great research, but to actually improve care for people. And we have work to do if we're going to be able to demonstrate that across the board in this program. So I'm going to walk you through first our successes and then some of the areas I think where we have challenges and we'll need to do some more work. So this is SPORE as it stands today. It is a complex program, Victoria. We've tried to boil it down to one slide. Currently, the program is almost fully invested for the next few years, and it's invested in 10 SPORE support units, 7 research networks, some of whom are represented in this room, and what we call 3 pan-Canadian teams that are enablers, enabling evidence synthesis, access to data, and capacity building. And as well, SPORE invests $11.5 million a year, approximately, in innovative clinical trials. This investment has and continues to achieve a lot. At the highest, what I think of as the follow the money level, SPORE has created change by putting time, energy, and resources into research that wouldn't otherwise have existed, into research on patient and community priorities, experiences, and outcomes. So this slide shows the total investment that CIHR made over 10 years, from 2011 through to 2021 at the end of our evaluation. And I really want to highlight that this was new money for research. This was not taking money from some other research that was already happening and investing it. It was a new investment from the federal government. Equally important, and why we call it Canada's SPORE instead of CIHR's SPORE, is that the program has a requirement that our CIHR's investment must be matched in cash or in kind by many other partners. And that I would regard as a real success of the program as well, is that together, the federal government, along with provincial partners, health research funders, universities, academic hospitals, other healthcare organizations, health charities, and the private sector have joined forces to invest in research on patient priorities. That's a real win, I would say. And it wouldn't exist without this co-investment, so that's something important for us, I think, to keep in mind as we move towards the future. The second success I like to highlight, and that our evaluation highlighted, was really around uptake of the research that SPORE is producing. And our evaluation highlighted some important data that show that there is good uptake happening. They did a search of SPORE-funded research that was cited in policy and guidelines, and found that SPORE-funded research is cited 2.7 times more often than the global average, which is great, and even more than what our much larger sister program, PCORI, in the United States is cited. So I was like, yes. And as compellingly, we're also tracking a growing number of really good examples of where SPORE-funded research is appearing in practice. Some of you may or may not know that SPORE is a big investor in integrated use services, and which is led here in BC by Foundry. And this is a quote from their research lead, who's talking about this really unique collaboration among service delivery and research. And these are the kinds of examples that were surfaced through our evaluation and that we're collecting, because I think this type of work where researchers are working hand in hand with people receiving services and with people delivering services to create that learning health system cycle is the kind of thing that really is what the SPORE vision is all about. And these are isolated examples, right? So our task is, how do we go from these really good, great examples and spread those out across other dimensions of healthcare, health policy and healthcare. A third success, I would say, is something unanticipated, and it was around the way that members of the SPORE community responded to the pandemic. And our evaluation found that while the pandemic did have a negative impact on the ability to conduct research, that the infrastructure that was in place through the support units and some of the networks was really important in helping to do some tasks and contributing to the pandemic effort. So we heard a lot of stories and a lot of good examples about how support units and networks were able to mobilize knowledge that was relevant to the communities they were working with. This is a picture from Hotitseta, which is the Northwest Territories support unit, where because they're governed by a number of Indigenous communities, they were able to very quickly understand what the needs were, like the information needs around the pandemic were within those communities, and develop materials that mobilized scientific evidence in a way that was culturally appropriate and effective. We also see, and I think this is the big one that a lot of people talk about, a culture shift in health research. There's good evaluation, there's good data in our evaluation from the key informant interviews, but some of the data I look at are above and beyond what our community has to say about the changing culture, the change in the culture of research. Are there independent indicators that we can also look at to help us, demonstrate that this is the case? And one of the things that I have the ability to do, working as I do at CIHR, is look at, well, what are the successfully funded research projects doing in terms of collaboration with patients and communities? And our team is trying to track and has already started to identify that many research teams that are now being funded are coming forward either with patients as partners in the research team itself, or with a really strong component of patient or community engagement. Here's just one example from a recent competition we led to set up training platforms for clinical trials, where SPORE actually funded 2 of the training platforms, but I think we had 4 or 5 that were successful, that had really significant collaboration with patients and community members built in, which is great. And a real measure of success, because it shows that the work that you all have done to grow that culture is now extending far beyond the initial investment. Another example is looking at strategies and policy documents. What are big health research funders focused on? So, Health Research BC has long been focused on partnering with patients, but it's in the strategic plan now. The same thing with the health charities. Increasingly, they're making patient and caregiver engagement a core priority, and they're using it in their advocacy work with the federal government. When they're submitting budget requests, they're saying, if you're going to fund health research, fund patient-oriented health research, which again is another measure of success. And then last measure of success, just what's happening at CIHR. So I was brought in not only to help the SPORE team manage this program, but also to think about how do we translate the lessons learned to other programs at CIHR. And one of the first things that I did was look around at what are we already doing as a health research funder. In this case, I was really amazed at the incredible amount of work that was started long before I arrived in terms of changing the culture to focus on patient-oriented research. So you'll be seeing in the coming months many important documents like frameworks around research excellence and knowledge mobilization, our new clinical trials strategy that have taken to heart the lessons learned through SPORE and are going to embed ideas and requirements around patient-oriented research into these big organizing principles for research. There are a ton of funding opportunities often through the institutes, the CIHR institutes, that are either co-developed with patients or communities, or are requiring researchers to co-create research with patients and communities. And then, of course, our evaluation has found that we're at a point where we just need to not get started, but get organized, I think, in terms of making this taking a systematic approach to patient-oriented research across the organization. So just to sum up, SPORE has created a lot of positive change in the culture and practice of health research, but as I said before, the impact of the program is still fragmented because we don't see, although there's great evidence of impact in individual projects, we don't see that being rolled up into greater impact for people's health experiences and health outcomes. And that's the vision for the program. So the good news is, because we're fully invested, this is our year to actually have a really important strategic conversation, what we're calling the SPORE refresh. And this is a commitment in CIHR's strategic plan. And I like to think of it as like, this is our year to have a pan-Canadian dialogue about what's working well and where do we want to go next. In this refresh and in conversation with many SPORE-funded groups across the country, we've identified 7 key themes, and these we can share afterwards if they're of interest, that we think the community will want to discuss. These include strengths and challenges for the program overall, what are trends just existing in the world in healthcare and health research that we need to take into account, delivering on truth and reconciliation calls to action, strengthening equity, diversity, inclusion, anti-racism, accessibility in patient engagement and patient-oriented research, continuing to build capacity for excellence in research, and what does that mean? Strengthening collaboration with policymakers and health services, and strengthening governance for Canada's SPORE, because I think there's still, and I think historically CIHR, although it has been a partnered program, CIHR has taken the lead in a lot of ways, and the feedback we've heard is that that's really not the approach that will benefit the program to the greatest extent. We need to take a more collaborative approach to governing this, since it's really Canada's SPORE. I want to talk about three of these themes really briefly, because they tie so nicely into the program and the topics of the program today. So let's talk about accelerating First Nations, Métis and Inuit self-determination in research through SPORE. So this is a big priority for Canada, the CIHR, as well as many other health research funders. It's part of, I think, our own organizational and our personal commitments to contributing to reconciliation. And patient-oriented research, as we all know, is really founded in concepts that align very nicely with this idea of supporting Indigenous self-determination in research. And yet, Indigenous health researchers and community members have identified a lot of challenges to actually making this a reality in health research in general and in SPORE. And some of these challenges that we have heard about include a lack of trust due to historical and ongoing harm, lack of consistent funding for research and the harm that that inconsistency can cause, institutional structures and policies that create barriers. And more specifically related to SPORE, although it's been a number of years that SPORE has had objectives and requirements related to partnership with Indigenous health researchers and communities in its major funding grants, we've had the requirements, but research teams have really varied in their ability to develop meaningful, mutually beneficial relationships with Indigenous health researchers and partners. I think here in BC, there's a lot for the rest of the country to learn about that. And that's actually why I was so excited to see these examples come up in the program. So one of the things that I think the country could potentially learn about, and I'm interested in learning more about being here, is the approach to relationship building that many of the BC-based SPORE-funded groups have taken. Here are just two examples in very different ways. Focusing on building respectful relationships with knowledge keepers and the careful attention to that. That CanSolve and the Diabetes Action Canada have taken in pulling together this resource, and I think there's a session on this resource today that I'm really interested in learning more. I think also of the memorandum of understanding that has been developed between the BC Support Unit and the BC NEIHR, and what does that look like, and what can that teach other parts of the country around what relationship building needs to happen in order for people to work truly as partners together to advance this important objective. A second theme, again in our program today, is around strengthening equity, diversity, inclusion, anti-racism, and accessibility. I think almost everyone in this room understands that there's a lot of work to do for many reasons. For some of the reasons that are captured on this slide, this is a slide that my equity strategy colleagues at CIHR have put together and reflects some of the things they've heard about the big challenges and barriers that are experienced by health researchers who come from equity-denied communities, and that also capture the challenges of doing research, health research, on issues of equity, diversity, inclusion, accessibility, anti-racism. And I think it's fundamental for us to address this and to do better. It's fundamental to the values that we say we have as a research community. It's fundamental to research excellence, because if we're not hearing from people with a diversity of lived experience, our research is going to be lacking. It's fundamental to creating policy and health services that meet the priorities, needs, and experiences of everyone who accesses our health systems. And again, I'm really excited to be here because BC's doing some really interesting work. So on looking at the program, I noted the Diversity Tapestry project. And what excites me about this is that it is a project that involved co-creation of resources around creating inclusive long-term care homes. But it didn't stop there. It wasn't just about co-creating an intervention, then it was about knowledge mobilization. And as I understood what information's been shared from CIHR, there's also some work going on to track, okay, we've taught people about this, is it actually having an effect on the quality of the experiences in the home where this has been piloted. And that's the kind of thing I think that holds a lot of promise for SPORE in the future, is that connecting of the dots, not just focusing on one isolated piece of work, but really understanding from end to end how co-creation can impact experience. The same thing with HDRN. I think HDRN, in a completely different way, is doing really interesting work in its effort to mobilize members of the public, but people with lived experience, around the idea of equity, diversity, and inclusion, and to educate researchers about how people would like their data to be used. And so there's a lot for us to unpack there and to learn from, and potentially to think about how do we want to move that forward in the future. This last theme is probably the one that keeps me up at night, because I didn't see examples that were specific, but you'll tell me if there are great examples happening in BC that I should be aware of. Victoria actually just told me about a really interesting one that UNBC has done with their local health authority. So the last theme is strengthening collaboration with health policy and health services. And the picture on the slide is actually 20 years old, right? It's the rationale for why SPORE exists, which is trying to bridge the gap between research and service delivery. And we haven't bridged it yet. But I think our SPORE refresh now is a really good time for us to think about what are our levers for bridging that gap, and how do we strengthen them? And in my view, it's that collaboration that is our major lever in the program that we need to work on. So how do we do that? What do we do? How do we make it more consistent and powerful? And I'll just throw one more in, in case I haven't thrown enough to think about. We need a new name. I think this comes up about once a week. Patient is a term that does not capture a lot of people's sense of who they are and how they want to participate in this conversation. And so I've given a few here. I'd love to hear sometime during the conference if you have an idea for what the name should be. But patient, not only does it not capture everyone who uses health services, but is actually, I think, alienating to some folks who see themselves as a member of a community, for instance. I've heard suggestions that we talk about person with lived experience, which is accurate but a bit ugly in English, at least to my ears. I've heard partner-oriented research. This is something that our colleagues in Quebec have started to use, and they like it because you don't have to change the acronym, and it captures kind of the essence of what we're trying to do. I've heard others in the community talk about patient, caregiver, and community research. So I'd really love to hear your thoughts on what do we call ourselves as we move forward over the next 10 years. So this is my call to action for you. Please join this conversation about the future of SPORE. It started this month. It goes until March 31st, 2024, and there are a lot of different ways to participate. In the conference app, there are some questions very specifically related to the SPORE refresh theme. So you can submit your answers there, and they will be sent to us at CIHR. You can join or host a local conversation. And we've shared a discussion toolkit with the leaders of each of the major SPORE-funded groups, so they can share that with you. Coming in January, we're going to have a public online discussion forum, so we'll spread the word then, but you can participate in a pan-Canadian discussion that way. We are hosting some by invitation virtual roundtable discussions as well in the winter, and you can always email us at the SPORE program. We will just take your input however you care to share it with us. So just to close, how many of you recognize this picture? A few people? Okay, so this is a place that, as I mentioned that I lived in BC. This is a place in Vancouver that's really important to me. It's the Morris J. Wask Center for Dialogue at Simon Fraser University, which is here in downtown Vancouver. And it holds a lot of meaning for me because I did my dissertation research there, and then I did a bit of work when I was a postdoc for the Center for Dialogue. And one of the reasons why I think about this place and how this place helps connect me to patient-oriented research and the work we have to do is that while I was there, I really gained an understanding of what real dialogue is. They taught us that dialogue is the art of thinking together. And this is our year to do that. This is our year to think together. And why that's so important is that no one of us has the answer for where SPORE needs to go. But if we're really purposeful in our process of thinking together, each of us can contribute a piece. And it's in that synthesis of all of our different pieces that we're going to find our way. And so I look forward to that process with all of you, to thinking together about how we can deepen SPORE's contributions to positive change in health research, healthcare, health experiences, and outcomes of the people and communities across this country. Thank you.
I'm like, is it working? Yay! Okay, thank you. Sorry, it's always the mics. That was amazing. Thank you, Amy. It was great to hear from you. Before we get going, I just want to open it up to questions here. If you have downloaded the app for our friends online, you can go into that session. I'm looking at mine right now. And in the agenda, click in, and you can add some questions and answers in there, well, questions for Amy in that section, and I'll jump in and read them out. For anyone in the room here who has any questions, feel free to raise your hand. And I believe we have someone who can run around with a mic, or I can donate mine and run out to you. So yeah, I want to open that floor up to questions for Amy. So I'm looking online as well. Oh. Oh, to the back there. Do you want me to bring mine out? I'm gonna bring mine out. Oh, I'm blocked by the chairs. Thought you'd break the ice. Okay, perfect.
Beautiful. For the terminology one, I think that's a really good question you're asking of this group, because you've got a lot of expertise here. By the way, my name is John Cherneski. I'm the PLEX program manager at the Praxis Spinal Cord Institute here in Vancouver, living with spinal cord injury. We had gone with the term consumer for many, many years. I don't know where the origins of that came along, but it was, I think, from the spinal cord injury community, they saw themselves as patients when they were in a hospital setting. So when you've had a spinal cord injury and you're in the acute or rehab phases, or even when you go to see your doctor, yeah, you're a patient in those moments. But right now, in this room, I'm not a patient. And I don't see myself as a consumer, I see myself as a contributor. So last year we did a bit of soul searching, and we came up with PLEX, person with lived experience, which is that same thing you were going with previously, but with a slightly different twist on the acronym, because I think it rolls off the tongue better. So that's my suggestion.
Thank you.
And
Is that on?
sorry, one last point. Yeah. With spinal cord injury specifically, we think about a person with lived experience as not just the individual living with the spinal cord injury, but the entire support network around them, because spinal cord injury affects not just that individual, but it affects their family, their friends, their care providers, as well. You know, we look to engage community organizations, advocacy organizations, who all have voices that need to be amplified in research and healthcare.
Thank you. I love that acronym. It's way cooler than the one we use internally at CIHR. And thank you for sharing that theme about how that a person with lived experience is actually a community with lived experience. I think that's something I've heard a lot from people managing all different kinds of health conditions and issues. And it's something that I haven't yet seen tackled in the way that we fund research or the way that we conceive of it. So thanks for raising that.
Awesome, thank you. And I'm going to pop onto one online. I know usually in events you don't have your phone out. I actually do, it's funny. So one of the questions we have here are, what are the barriers and enablers for putting PORE into policy?
So this is a great question, and I wouldn't call myself an expert, but I can say what I've learned from our knowledge mobilization team at CIHR, who have spoken with policymakers. So what they've learned is that there's a mismatch between the time frames, the incentives, the way the entire enterprises are structured. And so part of, research is structured for a, longer term time frame. There's a necessity to be rigorous. You're focused on publishing for a pretty specific audience in order to be rewarded in the system that you're working in. Policymakers, and I would say this as much from having lived experience and working experience in this area, are working on much tighter time frames. They're more pragmatic. The level of rigor isn't quite as high, although of course we want it to be as high as possible. And so really the issue is, how do we bridge these different realities that people are trying to navigate? So those are some of the barriers that I'm familiar with in a nutshell. And then I would say the one that we can all work on, regardless of what kind of system you're working in, is communication. Because each of us tend to get specialized in the language of our specific community that we're working in, and being able to translate into terms that other people will understand, I think often is a barrier as well.
Awesome, thank you so much. I'm just gonna check the room. Yes. Do you wanna pop up to the mic, or would you like me to bring it to you? Perfect.
Yeah. So I want to just raise the opportunity to actually push the experience the other way. I recently became a patient partner. I have a clinical background. And this hospital at home, the ministry wants it done. And for us sitting there as patient partners, we're giving our perspective, what we'd like to see for the experience, and sometimes our experience with the health system. So with this discussion, I'm going to go back and say, well, not only should we give those perspectives, you should capture them. And when we're going to structure the quality improvement and the evaluation, which we could call implementation research, let's collect those, let's look at those, and let's describe those and evaluate them. And then we can actually push them back the other way, because this is early days in BC for the hospital at home program. So, and back to the ministry and the health authorities and the policymakers, so it goes that way. So I just want to raise that as an opportunity, because lots of us, sit with these projects and we give our perspective, and it's captured in a report but doesn't go anywhere. So I think that's a mechanism we can think about.
Yeah, I think that's a really important point to raise, and I would hate to, if I wasn't clear, that I think it has to happen from both directions, right? So I think more coordination with policymakers and health service delivery leaders from the get-go is an important way to help move evidence into practice. And to your point, there's really interesting stuff that's happening in communities already, and what are the mechanisms to feed that back?
Yeah, and just to kind of follow up with that question too, because we had seen on the slides those statistics from 20 years ago in terms of research actually being brought into practice, and you mentioned there are still some gaps there. Do you have kind of updated statistics? Like, we are seeing a good change though, like it's starting to happen in comparison to 20 years ago?
So that is the problem that keeps me up at night. I don't have that data.
Okay.
That's what SPORE was designed to create. And so again, we're going, as a community, in the absence of data, we have got good stories, which are powerful and help to reinforce. Yeah, we think we're on the right track, but how do we move from stories to data?
Yes, definitely. Thank you. I'm just going to grab one from online again. Oh, go ahead. Oh, yeah.
Check, 1, 2.
Yeah.
Oh, there we are.
Fabulous.
Hello. Hi, Amy. I'm so thrilled that we were able to get you successfully to join us. And even though that was looking a little iffy at moments, because our production process for this year's conference has been very different, but welcome home in a manner of speaking, and just a thrill to have you with us. I'm going to pose for our collected masses one of the questions that you and I have discussed personally, but I'm interested to prompt your thoughts to share with our audience, and that is, how do we begin to integrate patient-oriented research, or what we for now have called patient-oriented research, into all health research?
that it is a great question. The other question that keeps me up at night, I'll say. So I don't think we're at the beginning, I guess, is my feeling. I think that it's starting to happen organically. As I mentioned, looking at the sort of different pieces of information I have access to, right? So thinking about, different health research funders are now putting it in as requirements. The risk that comes along with creating a requirement without having the capacity and the learning that everyone in SPORE has done over 10 years is that you can create cycles of tokenism.
Right.
And that's the challenge, right? It's like, how do we move a little bit more incrementally where we're slowly increasing the requirements, but we're also building capacity at the same time? I think that's what we have to do together in order to make patient and community involvement in research the standard. But it's not a quick fix. It's not a satisfying answer.
At least we're working on it. Thank you so much.
Yeah, thank you for that great question. So, these are pretty popular. So one of the questions that has come up quite a lot here is, does the fact of a SPORE refresh mean that SPORE will continue after the current funding?
Yeah, so SPORE is like what we call a ring-fenced funding program inside CIHR. So it's money that is given for a specific purpose, and that is continuing. And so the question for us as a community is to really think through, what are our new objectives, where do we need to go, and then what are the investments that need to be made collectively, because it's not just CIHR, but by partners across the country to keep going. So yes, SPORE, the program will continue, the specific investments, TBD, because we have to figure out where we want to go in order to figure out what to invest in.
Okay, great. And I'll jump back to the live audience quickly if there's anyone. Yeah.
Good morning. Thank you for the presentation. Lots of great information and very much a trajectory of moving forward, and there's some very good things happening. My question to you is, in today's world where public policy can shift the change of the wind sometimes by opinions or by our politicians who might see things differently without the data, maybe from a fear-based perspective or anything. And so you've got this momentum going for SPORE. What gives you hope for the future that this momentum will continue in the face of all those other environmental factors around us today that can sometimes get in the way and, quite frankly, many times will derail the really great things that are happening? What gives you hope for the future?
I mean, I think there's risk to everything. The advantage of SPORE is in that collaboration, because that's a source of insight that can help us understand where the winds are blowing, what are the priorities of the day, and can help us to connect those priorities that our elected officials have with research that's happening on the ground. So that's why, in some ways, I see that SPORE has a bit of an advantage among other types of research, because if we're doing our work well, we're already scanning our environment, doing what Victoria suggested, which is understanding what is it that health service delivery organizations have to do. I guess my other thought on this is that there's the world of health policy, and then there's the world of health service delivery. And I agree with you, at the health policy level, things can change quickly, or sometimes really slowly, depending on your perspective. In the service delivery world, which is where I spent a lot of time working, I worked in the quality space in Ontario, I saw so much opportunity for big, long-term changes that were not long-term sort of implementation work of policies that had already been created, but there's a lot of decision-making and influence at the implementation stage. And that's where I see a lot of opportunity for SPORE-funded research as well, is to be collaborating with those implementers where policy decisions have been taken, but the devil is really in the details in actually making it come alive.
Great, thank you, Amy. I'll pop back online again, trying to give everybody a good chance here. This is a great question. Should patient partners be involved right from the beginning of the study, even as part of the grant process, besides just providing a CHI number?
Yes. That's the intent, right? And so I will say, I don't know if you saw on the slide at CIHR, one of the things we did in our first sort of year of looking at what are we doing already, there's actually a fair amount of involvement of patient peer reviewers in the peer review process at CIHR. But what we've learned is that patient reviewers and other reviewers aren't always necessarily equipped to know how to assess the authenticity of the proposals that are coming forward in terms of the collaboration of patients and caregivers. So that's another lever that I think CIHR as an organization and other research funders have, is to do some work to increase the ability of peer reviewers to actually be able to judge, did the patient just provide, a token amount of input to this, or does this proposal really demonstrate that it was shaped by patients or community members?
Yeah, that's great, and it's something we've seen too in our organization, and when we have applications coming in too, right? It's that capacity bridging as well, because exactly that, you don't just want that kind of like, oh, we have the person on the committee. You want them to actually be able to like assess the application you're looking at, et cetera, right?
Yeah.
Yeah, that's fantastic. Oh, hello, yes.
Hello. I just wanted to ask, what do we know about the demographics of our patient partners? The reason I'm asking that, as a queer senior, I'm totally comfortable in my skin, which is white, which is very helpful. But I know many, many people aren't.
Yeah.
And I'm just curious, where is our patient research coming from?
Yeah, I think it's a really important question to ask. And in fact, a research group out of McMaster did the first patient partner survey. And what they found was that there's an incredible selection bias in terms of the people who are currently participating in health research. And the acronym I heard to describe the selection bias is WOW, White Older Woman, which I really like, actually. I like it, not only because I'm going to be a WOW one day, I'm on my way, but also because it acknowledges the contributions, the really important contributions of the patient partners who are already present, while at the same time recognizing that that's not good enough, right? We need to be hearing from all people and all communities in order to be doing the research that will, and translating that into policies for everyone.
Thank you, I'm a wow.
Oh my goodness. Okay. Oh, sorry, go ahead.
Sorry, I've taken a second dip in here. That last question around mitigating tokenism and ensuring that individuals who are partners on the grants that you fund are meaningfully engaged in their projects. So one, we've been working on in a sort of a grant engagement plan framework that really, I hope, when it's ready for prime time, will look to address what you should be putting into a grant application to really build it in really holistically and thoroughly and align it to all the research activities. But what I'm wondering is, does CIHR SPORE follow up with grant recipients, particularly the partners, after the grant's completed, to ask them about their engagement in the project, to evaluate, to see if they felt there was meaningfulness in it, or if they felt tokenized, to potentially look at lessons learned or anything like that, or is there plans to do that in the future?
Yes, we do. If you ask any of our grantees, they'll tell you we follow up way too often and ask for too much reporting, and that's something that we're working on, because I think it is important to follow up and understand. Our independent evaluation team at CIHR also followed up independently with patient partners who've been involved in research, and interestingly found there was a bit of a mismatch between the perceptions of researchers in the level of involvement that they had created for patient or community partners and the experiences of the patient partners themselves. So that's a really, I think, important finding and a signal for all of us in our research that we, in this community, that there's more for us to do to bridge that divide. And it sounds like what the tool you're developing sounds really promising, so please send it in to us so that we can learn from it.
Yeah, that sounds like an exciting resource for a lot of people. I am thinking I should be doing some closing comments, but I wanted to know if you would like to maybe answer one more question.
Sure.
Instead of having me talk about random things. So I can, I'll check on here, give it to one more person. So the question I think we could go with, because it's quite upvoted, should the new game go beyond an individual approach of engagement? So, for example, individual patient, the patient caregiver, to include experiences of health and illness that are thought and lived through the community where the patient belongs?
Absolutely. I think that's a really important, I think that's something we're hearing already, that patient-oriented researchers are recognizing, is that having individuals come to the table it's a lot of work, but it's convenient in a certain perspective. It's easier than going into community spaces and building relationships and gaining trust. But again, prior to working in health, I worked in community engagement, and I know from that experience that that's how you actually have to do it in order to hear from many people in our community, right, who won't come and sit at our tables. It's really important to go to where people are and where they feel safe and comfortable and rooted in order for them to want to share. And so, yes, I do think that's the direction we need to go.
Fantastic.
Thanks.
Well, thank you so much. This was such an informative and exciting session. I think there's a lot of optimism in the future here with everything going on. And thank you to everyone who provided questions. We still have a few more in here. I'm sure you could probably still send them up, and you can probably access them as well. And I'm sure you can try and hunt down Amy in intersessions too. But thank you so much, everyone. And I think I'd love to give another round of applause to Amy for her amazing presentation.
Thanks, Laura.